session in the hematopathology field, a field that is I respect a lot, and I wish I was a hematopathologist, but that's the career for everyone. We had an apology from one of the speakers, so the session will be shorter. However, we will proceed with the fourth session back-to-back with the chairmanship of Dr. Mohammed Al-Mohammadi. So we will start with the first presentation by Dr. Ghaleb Alyamani. Dr. Ghaleb is a consultant hematopathology and transfusion medicine, currently in the Prince Sultan Military Medical City in Saudi Arabia, in Riyadh. Dr. Ghaleb obtained his MD in 1993 from University of Cairo. Then he went in and he took his PhD in hematology and blood banking in 2005. Then he did hematopathology fellowship training in Toronto, Canada at SickKids from 2007 to 2009. So he's a FRCPC. Dr. Alyamani is a reviewer in many medical journals, and he is published. He has published many articles, more than 95 publications in peer-reviewed journal. And Dr. Ghaleb, it's an honor to have you with us today and to see the high-grade lymphoma case presentation. And I'm sure you will have your hematological and hematopathological touches. So let's learn. The floor is yours, Dr. Ghaleb.
Where is the screen?
We can see your screen, Dr. Ghaleb. Put it into the presentation mode. Yes, we can see it.
Okay. First, thank you, Dr. Bairote, for kind introduction. And thank you for scientific committee for inviting me to present the topic today, which is high-grade B-cell lymphoma diagnostic approach and the case scenario. So this is about the disclosure. This is my lecture outline. What is the high-grade B-cell lymphoma, and what is the patient presentation, and what is happening in new WHA 2016 for this category? What is genetic profile? And as we know, high-grade B-cell lymphoma is a little bit confusing. Some pathologists and also for clinician, if you tell the clinician your patient is high-grade B-cell lymphoma, he feel bad from the patient and he feel bad from himself, as he knows this patient will not responding to the standard chemotherapy, which are shop, and they need extensive chemotherapy, and they maybe relapse, and maybe need bone marrow transplant. And of course, so for pathology, he is confusing and also make a diagnostic challenge, because he depend on two issues should be very close to each other, which is the morphology. But the morphology is subjective from pathology to pathology, from pathology experience. And on the same time, they depend on the cytogenetic or fish or karyotype, which always not on time. So it is how to report the case of high-grade B-cell lymphoma. It is high-grade B-cell lymphoma, or it is diffuse large B-cell lymphoma, it is gray B-cell lymphoma. There is overlapping between each other. So what is the high-grade B-cell lymphoma? High-grade B-cell lymphoma is recently introduced category on WHO as aggressive mature B-cell neoplasm with clinical and biological distinction from diffuse large B-cell lymphoma and Burkitt lymphoma. Second. Okay. High-grade B-cell lymphoma, two categories. The first category, which is high-grade B-cell lymphoma with MYC and BCL2 and or BCL6 rearrangement. It is called double hit or triple hit, or high-grade B-cell lymphoma NOS, which lack a genetic double or triple hit, but have morphological feature intermediate between diffuse large B-cell lymphoma and Burkitt lymphoma, or have plastoid morphology. This is the definition of high-grade B-cell lymphoma. So double hit lymphoma should make gene rearrangement with BCL2 or BCL6. It is aggressive again, have mixed gene rearrangement in addition to other known oncogene, which is BCL2 and BCL6. However, mixed gene can be rearranged and with other gene like CCND1, which is characteristic for mantle cell lymphoma, can be rearranged with BCL3 also in 2% of cases. But in WHO, if mixed gene rearranged with CCND1, it is diagnosed as aggressive variant of mantle cell lymphoma. So if we have mixed gene rearrangement with CCND1 rearranged in the same time, it is double hit, but no, it is not considered double hit. It is a mantle cell lymphoma with aggressive variant. Similarly, BCL2, BCL6, BCL3, it is still not considered as double hit. So double hit, mixed gene rearrangement with BCL2 or BCL6 or triple hit. So double hit lymphoma have 4 morphological variants. As we see in this one, it maybe have diffuse large B-cell lymphoma morphology, which is the centroplastic variant. Maybe morphology between diffuse and the Burkitt with this one morphology. Maybe Burkitt-like morphology like the top one, and maybe lymphoblast like the blue and right one, this one. So we have 4 variants. Diffuse large B-cell variant, between diffuse and the Burkitt-like or lymphoblast. So it is difficult sometimes to differentiate exactly between morphology. And it is, as we mentioned, it is subjective from pathology to the other. Again, high-grade B-cell lymphoma, it is not new entity. It is a revised entity in the new blue book. Again, it is aggressive. The patient clinically presented by usually have advanced disease, stage 4, bone marrow usually involved, elevated LDH, usually have extranodal presentation, including CNS, high international prognostic index. So this is why clinician feel bad when you tell pathologist tell him your patient is high-grade B-cell lymphoma. Okay, now the category which was called B-cell lymphoma unclassifiable with feature between intermediate diffuse large B-cell lymphoma and Burkitt lymphoma no longer exists right away. It is now high-grade B-cell lymphoma. Okay, we start with a couple of cases how high-grade B-cell lymphoma is presented, how to diagnose, what is the diagnostic channel. The first case is 64 years old male patient presented by generalized fatigue, bony pain, night sweat, anorexia, and weight loss. Physical examination, the patient looks ill, cachectic, but no palpable adenopathy, no hepatosplenomegaly, or no skin lesion. CBC revealed anemia, thrombocytopenia, and mild leukocytosis. Peripheral blood film, no abnormal or atypical cell, only nucleated RBCs, 1%. So the patient did radiology, confirmed minimally enlarged mediastinal lymph node, mildly enlarged spleen and liver, as we said, 14.5 and 15.7 centimeter respectively. No abdominal lymphadenopathy. Okay, so the patient went to the bone marrow. The bone marrow aspirate, unfortunately, is suboptimal. Necrotic cells and a few intact were rare blast-looking cells. But the bone marrow biopsy was adequate, excellent, hypercellular, diffuse infiltration by malignant large mononuclear cell with blastoid morphology, looks like blasts, with a star sky appearance. So this is the bone marrow biopsy. this is a bone marrow biopsy. Is in the this is the low power. If you look to the on the left side, this area is necrotic, but this area fortunately have intact cells. It is very clear star sky appearance. And if you look to the high power, of course, any pathologist and some of clinicians also will appreciate this is large mononuclear cell. There is prominent nuclei, one or more, with relatively abundant cytoplasm. It is a blast-like morphology. So we expected leukemia based on, because we don't have flow, because it was, we expected based on the morphology, it is acute leukemia because there is no significant lymphadenopathy, no hepatosplenomegaly. So we did a flow cytometry, although the sample was suboptimal, but still we have some hematopoietic element. We gated on, if you look, we gated on the lymphocyte gate, which is the red one, and we detect small population of B cell, which is 19 positive. But if you look to the 19 and 23 is negative, the upper right quadrant. Okay, if you look to the bottom, there is also 19 and 5. There is no co-expression between 19 and 5. So 5 is negative. This population is B cell. Again, also 19 was 5. There is no co-expression. This separate population of B and T cells. If we look to the upper top, we will see a small population of the B cell is lambda restriction. It is monoclonal B cells. And express lambda, it means it is mature and also monoclonal, so it is not leukemia right away, because now we are dealing with mature B cell. Also, if you look to 23, again, it is negative. FMC7, if you look here, it is partially expressed. Also, again, CD3 with CD5 co-expressed with the normal. So CD10 also, again, negative. CD10 here is negative. So we can summarize what we have. We did immunostain. By flow now, we can summarize. We have B cell population, mature B cell population, lambda restriction, expressed CD19, and 20. FMCC is partially expressed. 5 is negative, 23 is negative. Also, we do immunostain to confirm this one, and we detect cyclin D1 is subset expressed. However, the other markers, BCL2, BCL6, CD23, all are negative. SOX11, which is one of the good marker for mantle cell lymphoma, it is not available at this time. KX7 was more than 90%. Immunoglobulin BCR confirmed monoclonal. So what's your preliminary diagnosis in such a case? How to report this case? Now we have bone marrow involved by mature B cell neoplasm. Morphologically, we reported like that. It is morphologically consistent with high-grade B cell lymphoma. But as we know, high-grade B cell lymphoma need to be subtype, and we need to confirm. We need cytogenetic, of course, for this type of lymphoma for proper classification and proper subtyping. So preliminary diagnosis, as we know, fish and karyotype usually coming not on time. So we reported this case like high-grade differential diagnosis, high-grade B cell lymphoma with double hit, which is double hit, or NOS, maybe CD5 negative mantle cell lymphoma with blastoid variant, maybe Burkitt lymphoma also have high KI7, have blastoid, although it is not morphologically looks like. Maybe also CD10 negative follicular lymphoma grade 3B, which you can also confusing with high-grade B cell lymphoma. The other issue may be diffuse large B cell. Those all are differential diagnosis. So what we need now, cytogenetic. Cytogenetic is very important to categorize this case. So we did fish. We detected CMYC is rearranged. We detected IGH CCND translocation 1114. So what's your diagnosis? It is a high-grade B cell lymphoma now, because we have mixed rearrangement, we have KX7, we have star sky, which is called aggressive morphology, or now what we can. According to the WHO, it is mantle cell lymphoma blastoid variant, because we have CCND1 translocation with IGH 1114, which is the hallmark in mantle cell lymphoma. So these cases reported as blastoid variant of mantle cell lymphoma. It is not high-grade B-cell lymphoma, although it is confusing. So cytogenetic is very important for such cases. Okay, so the final diagnosis, mantle cell lymphoma blastoid variant. If CCND1 not positive, it will be diagnosed as high-grade B-cell lymphoma NOS, because we have only CMYC gene rearrangement. We don't have other BCL2 or BCL6. So this is what so second case. So what learned from the first case? First case, you have high-grade B-cell lymphoma or blastoid mantle B-cell lymphoma can have the same morphological and immunophenotypic overlap. Second case is 57 years old woman without any significant past history who presented by flu-like symptom, and during routine workup, we discovered blast in the peripheral blood. See the blast in this. It is large, medium to large cell with prominent nucleus and mature. It has the morphology of the blast cells. Okay, we detected the WBC was 46. There is blast 72% in the peripheral blood. Based on that, we suggest acute leukemia for this patient as based on the morphological finding of peripheral blood. We did bone marrow again. So the bone marrow aspirate and the biopsy. If you look to the aspirate, again, there is infiltration by malignant cells, less condensed chromatin, scan cytoplasm, basophilic. It looks like, again, have a blast or blast-looking cells. The bone marrow biopsy is heavily infiltrated by malignant cells with blast-looking cells, again, small, medium to small, immature. So we did flow cytometry. Surprising flow cytometry giving us the positive for CD10, for CD19, for CD20, and the CD38 and 79A, and the surprising is Kappa is expressed. Kappa is expressed. So now, if Kappa is expressed, we likely deal with lymphoma, not with leukemia. The other marker, which in the slide, almost all markers are negative. T cell marker is negative. Lambda, of course, it is negative. The immature marker, TDT, CD34, MBO, cytoplasmic CD3, all these markers are negative. So we deal with high-grade B-cell lymphoma or B-cell lymphoma with aggressive morphology. We sometimes say aggressive morphology. If clinician, the pathologist tell clinician, I have B-cell lymphoma with aggressive morphology, it means we have frequent apoptotic pattern. We have star sky appearance. We have Ki-67 is high. We have usually the size is medium or large size. It is called aggressive morphology. So we did immunohistochemistry also to confirm. We did CD10 is positive, CD20, BAX, BCL2, and MEC is partially expressed. If you look carefully, it is partially expressed. As we know, to interpret the MEC gene, MEC expressed, we need at least more than 40% of the cell should be expressed. It looks like 40% or little bit less, so it is equivocal, positive or negative. BCL6 is clearly negative. CD34, TDT is negative. So we are dealing again with mature B cell. Okay, so what is the next step to diagnose this case? We have to, again, we do cytogenetic. We detected cytogenetic. We detect CMYC gene rearrangement. We detect IGH BCL2 rearrangement. And we detect second chromosomal abnormality when we in the karyotype. So now we have double hit, semic with BCL2 rearranged. We have secondary chromosomal abnormality, which is a common finding in high-grade B-cell lymphoma. Now this case is diagnosed as high-grade B-cell lymphoma with rearrangement of MEC and BCL2. So again, we have to diagnose this case. Without cytogenetic, we can't diagnose high-grade B-cell lymphoma. It is depend on MEC gene rearrangement and BCL2 rearrangement as well. So this is also what we learn from this case. High-grade B-cell lymphoma can be presented as a leukemic phase. So this case is presented by peripheral blood blast or blast-looking cells. So one of the differential diagnoses, when you see blast or blast-looking cells, the pathologist should all put your in mind maybe high-grade B-cell lymphoma as a differential diagnosis. The other important issue, kappa and lambda by flow cytometry should be included in your acute leukemia panel. Okay, so case 3. Case 3 is 64 years old male without any significant past history, presented by severe back pain, fever, night sweat, fatigue, and weight loss. So the clinical presentation looks like likely lymphoma. His physical examination is unremarkable, no lymph node, CBC revealed mild anemia, white blood cell 21 with 40% blast again or blast-looking cells in the peripheral blood and thrombocytopenia. Provisional diagnosis based on this finding, it was like acute leukemia. So look to the peripheral blood in the left side. See, it is very clear. Any pathologist see it is blast, prominent nuclear, immature nuclear chromatin, basophilic cytoplasm. So it is a blast. No doubt it is a blast. It is or blast-looking cell, whatever. The bone marrow in the bone marrow biopsy, see, replaced by malignant cells with blastoid morphology. So we did flow cytometry. Again, surprising, we have lambda-restricted clonal B-cell population expressing B-cell marker without TDT, MBO, or CD34. So we deal with B-cell lymphoma high grade with blastoid morphology. We did bone marrow some immune stain. BCL2 and BCL6 is expressed. With KI7, it was more than 90%, and also CD10 was positive. So what is the diagnosis? We have to do FISH. Again, in such a case, we have to do FISH. Now it is reported like, in such a case, we have to report it. In the next slide, how to report, because sometimes the FISH and the molecular study is not available on time to give a final diagnosis. We did FISH. We detected again MEC and BCL2 gene rearrangement, and also we detect secondary genetic abnormality, and the diagnosis finally is, this is the FISH, is IGH BCL2 rearrangement using double color fusion probe. We will see the fusion of this gene in these cells, and also MEC gene break apart. We'll see separate red and green signal indicating MEC gene rearrangement is rearranged. But as we know, break apart gene can detect MEC gene rearrangement, but he can't detect what is the partner, what is the other gene. Okay, so this usually, if we need to know what is the partner, we have to run the other probe. Okay, so what is the diagnosis? Again, diagnosis is high-grade B-cell lymphoma with MEC and BCL2 gene rearrangement. Again, he presented by leukemic phase. It looks like provisional diagnosis, it was acute leukemia. So we need, again, cytogenetic. So the last case is 52
You have
years
1 minute,
old.
Dr. Ghaleb. 1 minute, my dear.
1
minute. دقيقة واحدة.
Okay. 50 years old, medically free, presented by abdominal pain, neck swelling, 2018. CBC with normal finding, no abnormal cells. Radiological workup detected lymphadenopathy. Core biopsy is done. This is look to the morphology in the H&E. It is looks like blast-like. It's blast-like, but we did CD20 and the KX7. CD20 is strongly positive. KX7 is high. We did other marker. We did immature marker. It is negative. We suspected lymphoblastic lymphoma, but CD20 is strong positive. Immature marker is negative. So it is like we deal with high-grade BC lymphoma. We did FISH for McGear limit. It is negative. So diagnosis, it was diagnosed high-grade BC lymphoma NOS. Okay, the patient received chemotherapy and did autologous stem cell transplant in 2019. Okay, 2021, two months ago only, the patient presented by renal impairment, hypercalcemia, and lytic lesion, CBC, pancytopenia, no abnormal cells, bone marrow extensive by infiltration by malignant cells. What's your preliminary diagnosis? Everyone will expect it is a relapse. It was 2018 high-grade BC lymphoma, and 2021 is presented by bone marrow infiltration by malignant cell. It is relapse. Okay, this is the bone marrow aspirate and the biopsy. I'm not going in details. We did immunostain. It looks like infiltration by malignant with malignant cells, medium to large size. We did immunostain. CD3, CD20 surprisingly negative. Oh my. So what can we do? CD20 and CD. We did a lot of immunostain. A lot of every immunostain we did. What is the important? What we discovered? We did these two immunostain, which is 138 and CD56. It was positive, strongly positive 138. It is positive 56. So what's your diagnosis? The diagnosis is we did immunostain again. All are negative. We did ALK is negative. KX7. So what is your differential diagnosis? Of course, if we have case like that presented by this presentation was positive for 138 and 56, we have to think about plasmablastic lymphoma, plasmablastic cell myeloma, ALK positive, large BC. This is a 3 differential diagnosis in such a case, but ALK is negative. So now we deal with plasmablastic lymphoma or plasma cell myeloma, which is, we know it is a challenging, but presentation and the 56 and the patient presentation looks like myeloma, and this is diagnosed plasmablastic myeloma. And if we look, we have plasmablastic lymphoma and the plasmablastic myeloma have the same immune profile, depend only maybe sometimes the only diagnosis based on clinical presentation. It is if someone interesting, we publish 8 cases of plasmablastic lymphoma and discuss this issue, how to differentiate from other cases. So it is just a few 1 minute, Dr. Bairuti.
Okay.
Again, what is the aggressive morphology? Again, if we see a aggressive morphology, star sky appearance, high apoptotic, KX7. If we have a case of atypical with atypical MEC or BCL2 or BCL6 abnormality, not considered double hit. Like if you have the report of cytogenetic extra copy of MEC or extra copy of BCL2, it is not considered double hit. It should be rearranged, not extra copy or other abnormality. As we know, there is difficult to classify every lymphoma based on the morphology. As we have see, all type of lymphoma are overlapping. So how to can reach diagnosis? We mentioned this one, how the pathology report, pathology, how to report a case, because we know cytogenetic usually coming late, maybe second week or whatever. So we have in such a case, the pathology should write, according to the morphology, it is diffuse large B-cell lymphoma genetic study are pending, or high-grade B-cell lymphoma genetic study are pending, and the final WHO diagnosis pending on genetic study. And you have to comment on the morphology. It is more diffuse or high-grade B-cell lymphoma. Immunohistochemistry, you have to mention the cell of origin, double expression of BCL2 or BCL6, KX7, any feature raising the possibility of double hit, of triple hit like aggressive morphology, pending cytogenetic should be in the preliminary report. And as Dr. as Dr. Turki mentioned, molecular study in lymphoma and the clinical practice is coming soon. The next WHO will have implication of molecular study on the on patient outcome. The role is in therapeutic target and support the immune stain. So a lot of changes coming based on the next WHO based in the molecular. And this is how to approach a case of high-grade B-cell lymphoma. The last slide, what is the double expressive? You have to differentiate between double expressive lymphoma and double hit lymphoma. Double hit lymphoma BCL make with BCL2 or BCL6. Double expressive, it means based on immune stain, based in MYC gene rearrangement, MYC protein immune stain, and BCL2. The cutoff 40 and 50 for each one to be positive, and be in your mind, double expressive can be also in double diffuse large B-cell lymphoma 20 to 30%. What is the importance of double expressive? In some study, it has intermediate prognosis, and we have to differentiate between this one. And this is a differential diagnosis of high-grade B-cell lymphoma, and we overlapping, and we thank you عشان دكتور بيروتي خلاص جاب آخر.
شكرا دكتور غالب. I wish you don't stop, but all these are very interesting cases, very educational, wallahi. And it tells us how much the challenge you as hematopathologist you are going through to reach diagnosis. There are a couple of questions. The first one from Al-Junaid Ahmed. He's asking what makes some lymphoma double or triple expression with negative gene rearrangement test. I mean, hit. So
if you look back to my slide, maybe I wrote
you
it,
explained it in
but again, double expressor, as we have a common word, double expressor, not always rearranged. Okay, so if MYC is expressed by immunity, it doesn't mean it is rearranged. Again, double expressor, not always rearranged. It means MYC gene rearrangement, it is not a good surrogate for rearrangement. So we can express, but it is negative, and the vice versa. We can negative by MYC gene rearrangement, and it is positive by immune stain.
And as you alluded in your presentation, that the double expression, they are intermediate
Yes.
prognosis compared
Yes.
to double hit or triple hit, where they have worse prognosis.
Yeah,
The last question.
Okay.
Yeah.
Oh, this is why I showed in the pathology report. The pathology showed if we have large B-cell lymphoma, we have to mention it is BCL2 or BCL6, it is expressed or not, because they have clinical implication, as Dr. Bairotti said.
And the last question, Dr. Alyamani, I have is what we are looking in lymphoma is the molecular signature. Like for hairy cell leukemia, we have the BRAF molecular signature. For plasma cell lymphoma, the MYD88 molecular signature. When are we going to have the molecular signature in order to alleviate this integration of the clinical immunohistochemistry and the FISH studies, when we are going to have molecular signature of every type of lymphoma, if we can?
It is difficult to answer, but as we mentioned, molecular study and genetic study will be very, very important. As we said, we can diagnose high-grade B-cell lymphoma with double hit or triple hit or OS or whatever without cytogenetic. If we go back to my cases, in the first it is large B-cell lymphoma, maybe. So we have, without, I think, as we said also, next blue book is coming with a lot of molecular marker it is difficult. At least we have the basic one for every lab. This is what is the lesson from this lecture today. You have to prepare your molecular lab well, otherwise you will be outdated. Your patient not get the proper management or proper treatment. So as molecular marker is very important for diagnosis and for also outcome of the patient. Hopefully, we have like national laboratory molecular with all. I think someone told me it is in processing or something like that. We need national. Yeah, it is a big project. It is difficult to be in the private matter. It should be in the national way.
Okay. Inshallah, one day will happen at least either in the regions or at countrywide. We have a molecular diagnostic lab for leukemia, lymphoma, myeloma. That's a dream.
By the way, Dr. Bayroti, before we say it is time consuming, usually molecular is coming late in the couple of weeks or once. Now, as Dr. Turki said in the brief lecture, it can coming within a few days. Now, with new technology, with new machine, we can get the molecular testing on time.
Okay. So thank you very much, Dr. Ghaleb. Without